So I have some pictures to show you of some of those problems that can occur on the skin. And the first one that I would like to show you is a diabetic ulcer. Now, the usual diabetic ulcer is just as you see here, with a little pus and dead material down in the active part of the ulcer. The edges are a little raised and a little reddened, and the usual leg will be a little different from this because it is usually quite a lot larger and it is quite a lot more swollen. Because of the swelling of it, it makes the skin tense, and that tends to draw the edges apart more and to retard healing. So one of the things that we can do to improve the healing is to put on a type of bandage that will make the skin on the leg to pull together more so that the tissue can grow, can spread over, the skin surfaces can spread over the wound and heal it in that way. Now, another thing that we need to do with this ulcer is to clear up the pus and the dead material down in the active part of the ulcer. And there is a rigid bandage, which we call the Unna boot, which I would like to show to you now. And for that, I would like to have a product which you can buy on the market. May not go by this brand name, but it will have, or it may have, the name of Unna boot or Unna's boot, as this one does. Now, the Unna boot is the original, and of course we have used the Unna boot for I suppose 100 years or more, and it goes on very nicely even when you use the old-fashioned Unna's boot itself. And I have here the ingredients for the old Unna boot that we used to make up 50 years ago, and it is zinc oxide, which you simply measure out into a cup, and you get the formula properly for it, and which you can get online. And then you use glycerin, and glycerin can also be obtained from a pharmacy, as this one was, and the glycerin is mixed with it along with some gelatin, which you can get from a grocery store, just the plain Knox gelatin or any kind of clear gelatin which you can use. I suppose agar could also be used in this same way, but the Knox gelatin is by all means the best. And so you can make this yourself. It needs to be heated because of the gelatin. So the gelatin is softened in some water and heated to dissolve it, and then the zinc oxide and the glycerin put in, and then the foot and leg and the ulcer is wrapped with gauze, such as this, and then with a little paintbrush, the old Unna paste is painted on the first layer of the gauze, and then a second layer of gauze is wrapped on that, and it's allowed to harden and to gel, and that makes the rigid bandage. Now, while I have put on, I suppose, 100 Unna boots with the old-fashioned paste and the paintbrush, I would like to show you how to use this new variety. This is more expensive, but it's also it's so much more convenient. So I have asked an assistant, and that's Ariana Hartsfield. So Ariana, if you will come here and join me, and I would like you to sit right here. And Ariana is one of our students in our church school at Uchee Pines, and we are pretending that she has a large diabetic ulcer on her left leg. So if you'll remove your left sock, we will proceed to put on an Unna boot. Unna boots are extremely successful in, they'll both clear up the ulcer, they'll clear that dead and infected material up, and also will make the swelling go down and heal the ulcer. You can see it from one bandage change to the next. Okay, Ariana, if you'll let me have your left foot, and I'll just put this right up here on my knee. That's the very best way that you can put this Unna boot on. And then you just take the gel cast that you have, and it will be packaged very tightly because it should not dry out. And then you can see that it sort of sticks together a little bit like this. And on the ulcer, we will put a 4x4. So let's pretend that she has a big ulcer right here. So we'll put this right there, and then we'll put this on top of that, just like so. That will help it to stay on. And then we just wrap this on. It isn't difficult to put it on. It goes on sort of like a little cast. And because it is made of rather thin gauze, it is, of course, going to mold a bit to her foot. And this has to go down all the way to the base of the toes, as you see me doing here. The reason for that is so that the little rigid bandage, once it gets rigid, then it will be right at the base of the toes. And if you have to make it fit, then you can just twist it a little bit, as you see me do there. And then it goes back up. And if you will notice, you can see that there is some chalky material that gets on my fingers like that. This chalky material is the zinc oxide, which we had in the original Unna paste. The original Unna paste was a very good paste with the zinc oxide. One more wrap around the foot, and then it goes up over the leg. Now, the reason that it must go up over the leg is because the swelling needs to come down, but we don't make it tight. We simply make it fit, because the way that it's going to be functional is that her walking and moving and flexing her muscles will make it so that she will have the muscles to make the fluid go out of her leg. So we want it to go up a good way on her leg just for that very purpose. Now, each roll around leaves about 1/3 of the last roll exposed, so that it's not, you don't make one edge go to the next edge. You just make it about like this. Now, once it gets on, before they do too much walking on it, it has to harden. And that takes, with this commercial form, they will often tell you how long it's going to take, but it will often take maybe a couple of hours before it gets fully hardened. But it's not a big problem. Just make it fit, and let them have the time to have it to gel. Now, that looks as if it's about enough, so I'll cut this off right here. You can put the rest of it back in the watertight package and use this for the next time you put the bandage on. Now, at this point, we need to assume a couple of things. One is that a couple of days have gone by and it's time for a dressing change. So with the dressing change, the way to do that, you'll notice now that this looks like a cast. Looks like the casts that the orthopedists put on for a broken bone. That's good too. You can give it a little bit of a rub so that it makes it smooth. But when you take it off, you simply cut it off away from the place where the ulcer is. The ulcer is over here, and you simply cut it off somewhere away from the ulcer. So, as I am doing now, takes a little to do, although it will be once they have walked on it for a couple of days, and usually the dressing change is every 2 to 5 days, depending on the stage where the ulcer is. But let's say this one is ready to come off, and this is simply the way that you do it. And sometimes the patient can help you to get it cut off, but as you can see, it takes a little bit of working to get it off. Very effective treatment. I like it very much for the diabetic ulcers, and I'm sure that anyone who has experience with this will tell you the same thing that I have had. Now, usually after a couple of days of having the bandage on, the bandage will be a little bit loose on the leg, but the leg will be much smaller than it had been when you put the bandage on. Thank you, Ariana. We appreciate your working with us with this. It's a little bit messy. Now, as you can see, while it's a little trouble to put the bandage on, I can assure you that it's quite effective for this problem. Now, I have some other pictures that I would like to show you of other problems that can occur in the diabetic. So at this point, we'll look at a toe. Now, here you can see that this toe has a chronic ulcer on it. This toe may progress in the diabetic with an ulcer like that to amputation. Either the toe itself has to be amputated, or sometimes a portion of the foot, perhaps half of the foot, or even a below-the-knee amputation may have to occur for such an ulcer as this. This ulcer happened because a heating pad was used for the patient, and it got too hot, and this little ulcer developed, a little blister first, and then the ulcer which would not heal, and that points out the fact that diabetics should not have hot things put on the feet. They can't experience the pain like a normal person can, and therefore they have serious problems with excessive heat. Hot foot baths are best avoided. A warm foot bath at body temperature is about the hottest that a diabetic should take a hot foot bath, or a foot bath, not hot foot bath. Now we have another picture to show you. This picture also shows a typical problem with a diabetic. On the just behind the great toe will develop an ulcer on the sole of the foot. It's not an uncommon place. One of the reasons why it develops there is that the diabetic cannot see on the bottom. And often, because of weight, they may not be able to reach down and recognize that something is developing different on the bottom of the foot. And because the nerves are not sensitive anymore, then the person develops an ulcer before they know it. And it's a serious ulcer before they even know it. Now, the next picture that I will show you is also in a diabetic, also illustrates a typical problem. This problem is gangrene. You will see that developing in the right foot, the second toe. See, the end of that toe is black. That is called dry gangrene. But you will notice that on the left toes, there are 3 of the left toes that have a purplish red discoloration. If you were to press your thumb into that area of the purplish red discoloration, it might take as long as a minute for the blood to run back into the skin at that point. Whereas a normal person will have if you press on the foot, on a toe, the normal person will have the blood to run back into the skin in maybe 1 or 2 seconds. Doesn't take long at all. So you can see by that the diabetic is having a serious problem with the skin. Now let's talk a bit about how the diabetic develops an infection more frequently and more easily than the average person does. Because of the fact that when the blood sugar rises after a meal, the body's first objective is to get all of this sugar that's excess above the fasting level, to get all of that out of the bloodstream and put into various places where sugar can be stored. Now, sugar can be stored in muscles, it can be stored in the kidney, in the liver, and in the skin, and various other places. But the skin is an important immediate reservoir for sugar. So sugar is taken out of the bloodstream and temporarily stored in the skin. that makes the sugar in the skin go high. Sugar is a good culture medium for bacteria, so a small scratch, a little abrasion can result in quite a serious infection. And I'd like to show you some charts that I have that will illustrate this, the way that infection occurs. Let's take a look here at a germ itself. This is a bacterium, one with flagella, which are little threads with which the bacterium swims. So he moves these and propels himself along. Also, you will notice this. On the outside is the capsule, then comes the cell wall, and then comes the cell membrane before you ever get to the cytoplasm. Then the nucleus is down here. You can see by that that the germ is well armored to invade and has good resistance against us. But we also have very good advancing substances and advancing structures such as our white blood cells and the vast array of chemical substances that the immune system can produce. An amazing array of substances that are powerful to kill bacteria or to wall them off and make them so that they cannot move. So bacterium may be one without flagella. They don't all have flagella. Most of them, in fact, do not. But as something happens, let us say you get an infection somewhere on the skin or in the internal organs, and the germ gets into the bloodstream and goes to other parts of the body. You can get a meningitis from a germ called Neisseria meningitidis, and that is the germ most likely to affect the meninges. Then you can get a streptococcus that can infect a number of places. That can get in the bloodstream, can even go to the heart valves. You can get a Streptococcus pneumoniae, which can go to the lungs, and a Streptococcus aureus, which can involve the skin, and a Pseudomonas, which can involve the prostate, and a Salmonella, which can involve the colon, of course. And we're familiar with that from reports that we have had of people who have eaten infected meat or eggs or chicken, and this has caused them to get a Salmonella infection in the colon. So, of course, with these germs that can go all over the body, one can certainly see how these germs could either originate in the skin or could go from the blood into the skin. Now, let's take a moment for an anatomy lesson, if you will indulge me. This is a most wonderful illustration of the grand design of the human body. We have in bone marrow, and before we are born, these cells, which is called here a hemocytoblast or a stem cell. You may have heard of stem cell transplants. Well, here is a stem cell. We'll say that this is in bone marrow, and this is the red bone marrow, and this is the cortical bone. The red bone marrow, such as in ribs and in the breastbone, and other flat bones, the skull, the hip bones, these are, this red bone marrow is the place where these grow. Then over here we have the line that will form red blood cells, and here is a mature red blood cell right here in this area. Then we have what is called the granulocytes, and they develop from a stem cell, which can develop in any one of our blood cells. The stem cell, this is a myeloblast, and then we have over here the neutrophils, the eosinophils, and the basophils. Eosinophils are increased in number when we have allergies. Intestinal parasites, a very common thing to cause a very high eosinophil count. Certain collagen diseases can also cause a high eosinophil count. The neutrophils are our first line of attacking soldiers. They attack any germ that comes into the body, any bacterium that comes into the body, and will also move into any kind of inflammatory position. Then the basophils, we don't know as much as we would certainly like to know about basophils, but one of the things that we have recognized in the basophil line is that when there is a cancer in the body somewhere, basophils can increase in number. Then here are the monocytes. These are also called macrophages. They can also be called dendritic cells or macrophages. Very excellent fighting cells for us. All of these are good fighting cells. Then the lymphocytes, and one of their line can make antibodies, and plasma cells, which we used to think didn't have any good reason for being. Now we know that they are a part of the immune system and very important for us. Then way over here we have what is called a megakaryoblast, and the megakaryocyte, which develops from the megakaryoblast, has also platelets. These platelets have a very important part in our clotting mechanism, and in abnormal in times when there are abnormalities in the body and inflammation, these platelets can become sticky, and then they make a clot. If we get a cut, they can become sticky and make a clot. Now, in the urinary tract, we have some other problems that can be very common in diabetics, and I would like to just show you. Here is the adrenal, here is the kidney. Here is the cut surface of a normal kidney, and here is a dilation of the kidney pelvis because of an impaction of a stone that has developed here in the kidney pelvis and the top part of the ureter. So the ureter gets blocked by a stone, and we have a dilation of the ureter there. Here the ureter comes down and empties into the bladder, and the bladder can have, in the diabetic, may have cystitis or may even get a little ulceration. Here we have a jackstone type of stone in the bladder, which is not too uncommon. And here we have stones in the kidney. These stones, these kinds of stones. But then this stone is called a staghorn calculus. Now, a staghorn calculus is quite a find for the pathologist, and I have several in my collection of stones from various parts of the body. Stones that require a special license for prospecting for them, and so I try to hang on to them. They are now called semi-precious stones. Diabetics are more likely to produce stones than are others, and I hope that by our going into these things you can understand how diabetics must protect themselves in many ways, but by following a good lifestyle, they too can